We'll go ahead with that. So welcome everyone. Today we will be delving into the topic of antipsychotic medication or quality dementia care. So just a bit of housekeeping before we get started. So cameras are on for myself and the speakers, but as attendees you are automatically muted and your cameras are turned off. We will be holding a Q&A session at the end. So if you are not familiar with Zoom, just hover your mouse and a bunch of icons will come up and click on the one that says chat and you can pop your question in there and we will come to them at the end of the session. Thank you very much for joining us today. Today's session will focus on how and why antipsychotic medicine is prescribed, what alternatives might be considered, what choices do patients have, and what supports are out there for patients and families wishing to review their medication. So without further ado, I would like to give a very warm welcome to our special guest today, psychiatric pharmacist and researcher, Dr. Orla MacDonald. Orla studied pharmacy at Trinity College Dublin and gained a clinical diploma in psychiatric pharmacy from Aston University. She is also the lead research pharmacist at Oxford Health NHS Trust. Orla, thank you very much for joining us today.
Thank you. I'm just going to share my screen now, if I may. Brilliant. Okay, how's that doing? Can you see that screen okay? Great. Okay, brilliant. Thank you, everyone. Nice to see you all. So I am, as you say, I'm a pharmacist working in Oxford Health, actually not a doctor. I should have pointed that out beforehand. But yes, I work in Oxford Health. I've been working for 20 years in psychiatry over here. And I'm also a member of the College of Mental Health Pharmacy, which is a network of specialist psychiatric pharmacists and pharmacy technicians. But today I'm here to talk to you about antipsychotic use in dementia, and it's following a piece of research that I did with a research group in the Department of Primary Care here in Oxford. This group uses a platform called ostensibly, and ostensibly is a phenomenal platform that gathers data from GP records right across England. And so we gathered, the data included almost 60 million people's GP records. It's anonymous. We don't ever get to see any kind of patient confidential information, but what we can do is we can pull things like prescribing information, look at antipsychotic prescribing trends. And so within that data, we had over 275,000 records from people who identify as Irish. And of that, it included people with diagnosis of dementia, learning disability, etc. And so this piece of research pulls this data, and what we were looking at was the prescribing of antipsychotics over the course of the pandemic. And we were particularly interested in the prescribing in vulnerable groups. So the groups were people with dementia, people with learning disability, people who were in a care home, or those with autism. And the reason we were especially interested in whether antipsychotic prescribing had changed within these groups is because we know that antipsychotics can be used in the short term for behaviors, what are known as challenging behaviors. So where somebody may be doing something that puts them at risk to themselves or puts them at risk to others. And also they can be used for severe agitation and distress. And we were curious to see whether the pandemic, and in particular the lockdowns, created a scenario where people were needing to turn to drugs more than what are recommended, the non-pharmacological therapies, to manage this kind of distress and these behaviors. So that was the purpose of our research. And what we found was that rates of antipsychotic prescribing in care homes and in dementia did go up. In particular, there were a couple of peaks in at the beginnings of lockdowns, where we saw very significant increases in prescribing of new antipsychotics. That's not so much shown on this slide. Some of that we think is related to the use of antipsychotics in end-of-life care. So particular antipsychotics are also used in palliative care when somebody is coming to the end of their life. But actually, this trend that we're seeing of antipsychotic prescribing increasing and continuing to increase after the pandemic is not likely to just be related to end-of-life care. So it does raise questions as to whether we need to do further promotion to try and help manage the use of these medicines. And so that's why I'm here today, really, is to have a conversation about why antipsychotics are used in dementia and what alternatives could be used, and also just the kind of mechanisms by which things are prescribed and how prescribing can be reviewed and medicines can be stopped. So when might an antipsychotic be used in dementia? Well, we know that dementia is a condition that can cause people to become very distressed, very agitated. A lot of this may be due to the illness itself and how it's affecting the brain, but it also may be due to the reaction of, for example, losing the ability to communicate, losing the ability to do things, losing independence, and all of those things understandably can cause huge frustration. And I think communication in particular, with certain people, they forget words, lose words, and their ability to be able to communicate emotions and feelings can go quite early on, and it creates huge frustration and confusion. So we see a lot of these behaviors. It's very common to see people with dementia developing something like the behaviors described here. And in fact, collectively, they're all known as the behavioral and psychiatric symptoms of dementia. But indeed, we wouldn't say every patient would develop all of them. What we would say is it's very common for people with dementia to, at some point in their illness, to develop some of these symptoms. And in fact, when I say very common, we're talking about almost 100%, certainly over 90% of patients with a diagnosis of dementia will develop some kind of behavioral and psychiatric symptom over the course of their illness. Now, an antipsychotic should only be used if the symptom that they're displaying cannot be managed by non-pharmacological means, so by other methods, or if it's causing severe distress to the patient, or if they're putting themselves at risk, either to themselves or to others. And so the antipsychotic is really considered a kind of a last resort to manage these symptoms. However, you can imagine, because so many people with dementia will develop some of these symptoms, we do quite commonly see antipsychotics being prescribed. There are only 2 antipsychotics that are actually licensed for this. One is called risperidone, the other haloperidol. And in both cases, they're only licensed to be used for a short period of time, so 6 weeks maximum. And I'll go on in a bit to talk about what NICE says about using antipsychotics, but it's just to understand, whilst there are only 2 that are licensed, it is quite common for other antipsychotics to be used, even though that would be considered off license. So we don't just stick to those 2 if a patient, for whatever reason, couldn't tolerate either risperidone or haloperidol. We might try one of the other ones, and it would be considered off license in that case. But like I say, antipsychotics should not be used as the first option. So just thinking about what else we might do or to help somebody who has behavioral or psychiatric symptoms of dementia, in absolutely every guidance and every piece of recommendation, you will see that it's the non-drug options that are recommended first. And that very much is about individualized care. You couldn't have a blanket, this template of what you must do. It's very much about thinking, what is it with that patient that is making them distressed, that's causing agitation? Certainly, we often see it being people's levels of agitation varying throughout the day. Sometimes you'll find people's day-night cycle can become switched, so they'll be very settled, maybe sleeping a lot in the day and awake a lot at night. Sometimes you'll find a lot of people describe sundowners, and what that really means is that people tend to get more alert in the evenings and perhaps more agitated in the evenings. And in those kind of things you manage by having really clear structures in the day, really active daily plans, planning for that time when that person will be more alert. Sometimes it's a case of thinking about what particular triggers might be there for that person. And it might be that getting dressed is particularly difficult for them. As dementia develops, it's extraordinary how people can lose the ability to do daily activities whilst being able to do other activities very well. So things like dressing, putting on jumpers requires quite a bit of coordination. And it might be that you need to change to different clothing, jackets, cardigans to make those tasks easier. So like I say, it's a very much an individualized care when trying to think what is causing the distress, what is causing difficult behaviors. Is it a change in environment that somebody is struggling to settle into? But also the really clear thing is that a lot of these behaviors are very much short-term. Dementia is such an illness of change. People go through phases of being unsettled, phases of being really quite confused, and the following couple of weeks, months, they can become much more lucid in their thoughts. So it is an illness of change. And certainly if somebody does develop even a quite severe agitation or hallucinations or anything like that, it would be a temporary thing. We would expect it to pass over time. Another important thing to mention is that we do have to think, well, is there something physical going on? Especially if somebody is losing the ability to communicate well, is it possible they're in pain? Have they got an infection? Urinary tract infections are very common. Constipation is very common. And it can just cause physical discomfort that we need to think about and address. So we might prescribe in somebody with dementia, but we'd be prescribing meds like painkillers or laxatives or antibiotics before we'd be trying to use anti-psychotics. I've just identified there, obviously, depression and anxiety are considered part of these behavioral and psychiatric symptoms of dementia, but we do not treat depression with antipsychotics. We should treat depression with antidepressants if a medicine is needed, and similarly for anxiety. So obviously there are very clear guidance for how we treat depression. Psychological therapies have a huge role to play, but if we do decide that we need to use medicines, we would use antidepressants rather than antipsychotics. And similarly for an anxiety disorder, we should use antidepressants to treat that. And the treatment duration, the treatment plan would be different. For an antidepressant, you would expect somebody to stay on that medicine for 6 to 9 months at least. So that's just to highlight that there. And also, I mean, I've mentioned there about sensory needs. Again, that's one of the kind of non-pharmacological approaches. People with dementia often have struggle with light. They become very sensitive to light, very sensitive to sound. And that's part of how the brain is adapting to what's going on. But really, you know, managing those kind of sensory inputs can have a hugely positive impact and avoid the need for kind of medication to manage the behavior or the distress. So as I say, NICE, which is the National Institute for Care and Health Excellence, that is very clear about the remit for when we might use antipsychotics in dementia. It is considered a kind of a last resort. So when somebody is either severely distressed or really at risk to themselves or to others. But it's very clear that the antipsychotic should only be used for the shortest period possible, and the person should be reviewed at least every 6 weeks. So if you imagine the license for the drug is saying you can only use it for 6 weeks, realistically, people will use it for longer because it might be that that level of distress is maintained for longer. But certainly if you're using it for a long period of time, you need to be reviewing it regularly. And that should really be a specialist review. Some GPs may be happy to do that review, but all of these drugs are started by specialists. So that means a consultant psychiatrist. And as soon as the antipsychotic is not needed, it should be removed. Now, taking out an antipsychotic takes time. We withdraw them gradually for 2 reasons. First of all, we're trying to see we're kind of cautiously seeing whether it might still be needed. So as you're removing it, you're assessing to see, are some of those symptoms coming back? But secondly, as well, if you stop, depending on the dose that's been put in, with lower doses, it's less of a problem. But if you've had to use a higher dose and then you stop it suddenly, you might find some kind of withdrawal symptoms like blood pressure changes and things like that. So we do have to take these drugs out slowly. Now, by and large, we use very low doses with antipsychotics in dementia, partly reflecting the fact that people who are elderly and frail, they metabolize drugs slower, and they are more sensitive to side effects. So we do go in with very low doses and we increase the doses very cautiously. But we still might find ourselves after a cautious increase on a reasonably strong dose, and that therefore we would say that does need to be removed gradually. I just wanted to touch on the issue of consent because it's a really important point to raise when you're talking about prescribing any medicines or deprescribing. Obviously, in any kind of medical intervention like this, we need to get patient consent to do so. Now, consent is a very tricky issue in people with dementia because we have to be able to make sure that if they are consenting to treatment, that they understand what they're consenting to. And quite often, people with advanced dementia certainly don't have the ability to, don't have capacity, and capacity is the word that we use, to really make that informed decision. So capacity isn't just about being able to hear the information, it is about being able to hear it, process it, weigh up the pros and cons, and communicate back your decision. And if any of those systems are impaired, essentially, we have to assess whether somebody has the capacity themselves to consent. And quite often in dementia, we would say people might not have the capacity to consent. And that's where prescribers will look to the families, the next of kin, the carers, for support in making those consent decisions. They will have what's called a best interests discussion, where they think about whether the key things about the best interest discussion is you're thinking about what would this person want for themselves. one of the key questions they will ask is it possible this person would regain capacity? And that is actually, certainly in the early stages of dementia, that's a very reasonable question to ask. We do see people having periods where they're really quite confused. And then, like I say, periods shortly after where they're much more lucid and able to make decisions for themselves. So capacity can come and go. And it always needs to be assessed upon every decision. You need to assess capacity. And if it's about, starting a treatment, the first question you'd ask is, could we wait until maybe they have capacity? And if that's not a possibility, then it's a question of getting other people to help make a decision that is using the knowledge of that patient, what they would have wanted themselves, what their expectations culturally and all the rest are. And all of that's documented in a best interest discussion and needs to be documented before the prescribing is done. The reason I raise this is because as that medication is reviewed, those capacity conversations still need to be had. And if you were also then thinking about deprescribing anti-psychotic, you would again need to have that best interest discussion if the person doesn't have capacity to understand that decision. So it's not like you do it at the beginning and never think about it again. It's a really routine, regular conversation that you have to have and constantly document whether the person has capacity and what the best interest discussions were. So I thought I'd briefly go through some of the possible negative side effects of antipsychotics. I don't want this to be seen as a kind of a scaremongering process at all. Antipsychotics, as I say, they can be incredibly effective and really reduce distress and be an absolute lifesaver for both the person, the patient, and for their family care members and carers. But like any drug, they do have potential side effects. And really, the point is that antipsychotics don't treat dementia. They don't remove the cause. They don't improve memory. They don't improve cognition. In fact, some antipsychotics, because they can make you quite sedated, they might have a negative effect on cognition. So, you're putting in a drug that's managing a symptom. A bit like if you were in pain and you used a painkiller to manage a symptom. Whilst the symptom is there, it's reasonable, but once that symptom passes, you don't need the drug anymore. And so it's sometimes, when we use antipsychotics, these are the kind of things that we worry about them causing as a negative side effect. They can, as I say, be quite sedative. Now, sometimes that's a positive initially, but that drowsiness can add to confusion as well. They can cause what we call movement disorders. So where you feel quite stiff and sometimes get a bit of a tremor, a shakiness or jerkiness with your movement. And again, in somebody with dementia who's at risk of falling, these are obviously not ideal side effects. Now, these are dose-related side effects. So we find that if we use going in with that lower dose helps, but if you found that somebody has had an increase in dose and suddenly you're finding they're looking a bit stiffer in their movement, finding it harder to say open things or handle things, it might be that drug is having a side effect. And we manage that by reducing the dose. They can increase risk of kind of retaining water, increased risk of infections, particularly things like chest infections. And they can as well increase a risk of having a stroke. Now, that's a really important one to point out because it's one that's been highlighted a lot over the last 10 years. It's kind of the epidemiological data has really brought out the information on antipsychotics and stroke. And so I just had an additional slide there to help understand what we mean by risk. The risk of stroke in dementia is very small. So if you had 1,000 people who had dementia, 8 of them would be expected to normally, under normal situation, without having an antipsychotic, have a stroke. So that's the darker collection in the corner. If you add in an antipsychotic, you add an extra 12 people will have a stroke. So that's a kind of a way of explaining the added risk. It's still a very small risk, but it is increased by having the antipsychotic there. And so that data, originally it came out with one or two, it was mentioned with one or two of the antipsychotics, but now we believe it's probably the case with all of them. There isn't an antipsychotic that is going to be safer than another when it comes to risk of stroke. And obviously we do need to bear in mind, well, if somebody has other factors that further increase their risk of stroke, then we do have to be quite careful about using the antipsychotics. So really, this is the point of today, was to raise awareness and kind of help people to understand how they can help if their family member is prescribed an antipsychotic. And what I hope I have explained today is how the illness itself presents us with these behavioral and psychiatric symptoms of dementia. That is part of the illness, but these are temporary things. As the carer, you and the family member, you know that patient best. You are the best person to be able to identify what non-drug treatments might help, because you know what matters to that person from a cultural point of view. You will be able to, if that person is in a care home, you'll be able to give the carers information about what their likes and dislikes are, because these are the kind of things that will trigger confusion and distress if the patient themselves is not able to communicate. And really, I wanted to make it clear that the antipsychotics are there for a reason. The reason is to treat these symptoms, but they really are there short term. And there are two reasons I want to make that very clear. First of all, you know, the people who are most affected by these behavioral and psychiatric symptoms, apart from the patient, are the families and carers themselves. And so they're the ones quite often going to the prescribers and saying, I need help, please can we think about using something? And that's why the antipsychotic has started, quite reasonably. But when the antipsychotic has been incredibly effective at reducing these behaviors, it can be then alarming, terrifying to think about it being stopped. And yet the professionals, I hope you can see now that the professionals really do have an obligation to review and de-prescribe those antipsychotics. That is how they're told to prescribe. And so they will constantly be thinking about pulling that drug out. And so we have quite often, and I've seen this certainly in learning disabilities, which is another area where we see antipsychotic prescribing, we have a balance between people who are keen for the drug to be stopped, but we also have families who are absolutely terrified about the drug being stopped. And what I will say is that, you know, at any point when it is reviewed and there is a plan made to de-prescribe, it is pulled out very slowly and always should be done in communication with the family, because there is most likely going to have to be a best interest discussion made at that time as well. But also there are those who I know who might be worried that actually the medicine isn't being reviewed as promptly as it should be. And look, you know, since the pandemic and even beforehand, we know that our GPs are incredibly busy. Our psychiatry services are incredibly busy. And the reality is, if somebody is calm and quiet and not causing trouble in a care home or causing distress, then it's easier for these very busy services to overlook them and forget that actually there's a medicine there that needs to be reviewed. So there's two sides of the coin, really. There's those who who are needing the review. There's those who are having the review. It creates anxiety. There's those who are actually needing the review. And I suppose as a carer, I just want to encourage you, it is appropriate to say, you know, is this medicine still needed? NHS England has recently really emphasised that it wants to reduce overprescribing, and in particular, it's putting a lot of resource and effort into reducing overprescribing in those who are frail, who are vulnerable. So there have been many kind of initiatives proposed, but one of the key initiatives, which is worth looking out for, is that most GP practices now are starting to employ practice network pharmacists. So you might think, oh, I don't want to ring my GP, he's terribly busy. But instead, you could ring your GP and say, could I please speak to the pharmacist? Now, the pharmacist might only work there 1 day a week. They might cover 3 or 4 GPs in the area. But that job, the actual job of the pharmacist, is to do structured medication reviews. That's what they're there for. They work for the practice, so they know all of the patient history. They can see what the patient's been on, when it has been started, who recommended it. They also have been told by NHS England to focus on patients who are frail, who are elderly, who are vulnerable. So it's not going to come as a surprise to them if you turn up and say, actually, I've got my elderly mum here and I think she needs a medication review. But equally, you might find you get a conversation or a telephone call from a GP practice pharmacist saying, could I invite you in for a medication review? Because it is being promoted through these professionals. Now, I would caveat that with saying, because antipsychotics are prescribed and initiated by specialists in secondary care, it's likely that a practice network pharmacist won't de-prescribe, but they can certainly be a great source to start that conversation. If you're thinking, well, it needs to be reviewed and I don't know who to contact, that would be a great start, because they can then refer you on to other professionals to have that medication reviewed, and they can certainly talk to you about any kind of possible side effects, etc. So I've ended there with a list of resources. These are links where you can find out more information about antipsychotic prescribing in dementia, and the very final link there is, in fact, the description of what NHS England expect from practice network pharmacists when they're doing their structured medication reviews. These slides will be available afterwards, so you should hopefully be able to access those links. And I can stop sharing, and I'd welcome any questions.
Thank you so much, Orla. That was a really helpful and very clear presentation. So now, to encourage anybody who would like to ask a question, you're welcome to type it into the chat, and then we'll put it to Dr. Orla. It will be anonymously. And to start off, perhaps, Mary, could I bring you in to ask a question here to begin with?
Unmute. Yes, that was brilliant. That was really helpful, Orla. I've learned a lot from it. It's more of a comment and maybe a bit of advice from you. You highlight the importance and the need for family members sometimes to question whether somebody should be on these, or whether and when it should be reviewed. I think that's really important. I suppose an issue that I find with the Irish community, but it's the same in other Black and minority ethnic communities, they don't want to rock the boat.
I know.
They're very accepting of authority.
Yeah.
They have high expectations that doctors and staff in care homes know what's best for the patient.
Yeah.
And they're reluctant to ask. So I think what you've done with your session today, I hope we've got a good pickup of it, is that people will actually start to question. They'll have the courage to initiate a discussion about it and a review. So I think that's really important.
Exactly. And I think actually you'll find one of our, in the resources that I've got there, there's a really helpful decision aid that if you were kind of feeling a bit anxious about turning up to a GP and saying, oh God, I don't know whether to ask this question, you can print it off and just say, look, I found this and I was reading it and I was just wondering, you know, on this basis, what the plan is for my mum or dad's antipsychotic, and that really is. But like I say, that's why I feel these practice network pharmacists are a great first step as well. I hear what you're saying, and I think as well, when you've lived in Ireland and had to pay for GPs, you often, I think we're even more reluctant to make appointments to see our GPs because you know, it's just seen as such a valuable resource and you don't want to waste people's time. But it's really important, you know, and I think getting medicines right, I cannot underestimate how much the NHS England have prioritized this. They really want to get medicines right. So part of that is people coming forward and saying, actually, I think something needs a review here. So it's from the top that people are encouraging us to get this, to have these conversations and to have these medication reviews.
I think it's really important. Thank you very much for that.
We have a question, Ola. You were talking about GPs and doctors, especially since the pandemic, being known to be incredibly busy. So what would you say to family carers who might be thinking that perhaps a review of medication would be useful, but are anxious about taking up the time of the GP? What would you say to them?
Like I say, I think if people were to, you know, they might find that their first port of call would be that practice network pharmacist, because they even if they rang the GP, I think these days, and said, I'd like to talk to somebody about review of their medication, the network pharmacist might be the person you're put in touch with. And that's a great thing, because that is their role. The problem is, and again, I emphasize that a lot, these are specialist drugs and they need specialist review. And so I'm not going to be kind of overly optimistic and say, oh, it'll just require a telephone call and it'll all be sorted, because almost certainly what it'll do is you would make the appointment to see the practice network pharmacist, then they can discuss further, refer you back to secondary care. It does depend though on the relationship of how of the care wherever that person is. So for example, if they're in a care home, it might be that the care home knows that the psychiatrist visits once a month. And so it might be that you just directly say to the care home, well, I'd like to leave a message for the psychiatrist. I'd like to, you know, speak to him the next time he's there. So it does depend on where that relationship is. But like I say, this is the resources are super clear about what the expectations are. And so the expectation is not necessarily that the drug is removed immediately after 6 weeks have passed, but that the drug is reviewed routinely. So kind of just being prescribed an antipsychotic and then left on it, and nobody looking or thinking, you know, does that need to be there still, is not appropriate. Everybody would agree that's not appropriate.
Thank you, Ola. And we have a comment in the chat that's come in to say thank you, and that you've given this person's sister-in-law confidence in challenging the medication that her mother is on. So thank you for that.
That's okay. Good. Yeah. And like I say, you know, anytime there's a plan to deprescribe it, it's always done very gradually, should be done with a family involved, because the families are the ones who are going to pick up if anything comes back, if any of those symptoms start to get worse again. So it really should be done with the families and carers support. I saw there was also another comment there just briefly about the impact of antipsychotics in children. And it's probably not one for this conversation because, you know, antipsychotics rarely are used in children, but obviously there's a learning disability population who have a fairly similar, or rather, I could say a lot here about learning disability that's a bit similar. It's about managing kind of using antipsychotics for the short-term management of agitation and challenging behaviors, and it's exactly the same principles, that it should be short-term, it should be last resort, you should be using the non-pharmacological methods first. So if that comment is with reference to a child with a learning disability, it is very much, perhaps the resources I've included here are not as relevant, but maybe we could do something at a later date about learning disability, and that would be fine.
Thank you. I want to bring in Ellen here, who is our health coordinator at Irish in Britain. Ellen, would you like to put a question or a comment to Orla?
I would, sorry, just trying to unmute myself there. Yeah, Orla, I thought something that was really interesting was about the GP practice pharmacist. And I was wondering, how new is that, and do many people know about it, or how has that word been shared? It's just something I'd never heard about, so I just wondered.
It's really quite new. So what happened is, I mean, it's only kind of 5 years since the NHS turned around and said, we're going to employ these different professionals to try and help out GPs with the workload. And in fact, GP networks themselves, they're kind of their own business. And so they employ the practice pharmacists, but they've got funding to do so. And indeed, it's not just pharmacists, it's a whole range of other healthcare professionals that you start to see more and more in GPs. And a lot of these pharmacists, therefore, are quite new in the role, which is it's great that they've got them there, but certainly the initial evidence of their benefit is reflecting that a lot of them are still finding their feet. And those of us who work in secondary care are also still finding our feet in how we can collaborate really well with them, because we've got an expert knowledge, they've got more generalist knowledge. So I would say that the concept is fantastic, and certainly the purpose, their role is very clear. It's to review medicines and optimize medicines in patients. So huge kind of cohorts of patients, but they will be prioritizing people who are on polypharmacy or at risk of adverse effects or high risk medicines. That's going to be their role. Like I say, most GP practices now have looked to employ one. Now what they'll do is a practice is usually part of a network, and the network might employ one pharmacist. So the pharmacist might be in the practice only half or 1 day a week. But certainly if your GP doesn't employ a practice pharmacist, then it is the GP you'd have to speak to about medication review. But if they did, they're a great resource. So I don't think they have been particularly well advertised. Like I say, and a lot of them are only currently putting people in their post over the last few years. Obviously, the pandemic messed up lots of this momentum, but it's really gaining momentum now. Yeah.
Thanks, Orla. No, I think it's great, especially because I know a lot of people, as you mentioned that people are they don't want to waste their GP's time when they know they're so busy. So to know there's actually this GP pharmacist, that's actually one of their sole purposes, it's brilliant. Yeah. It shows how important it is to continuously review your medication. So thank you.
Exactly. And I think it's, definitely, because the community pharmacists, which are very helpful, those who work in the kind of community, the shops, the difficulty is they don't have any access to patient notes. Yeah. So they don't know the history. They can't see where something has been started. So you could talk to your local And you might find a very helpful, knowledgeable pharmacist, but they're limited in what they can tell you. Yeah. But the practice pharmacist can see all of the history. Yeah.
Thanks for that.
Ola, I'm just going to read out a question from the chat, and then we'll bring Mary back in again. So the question is somebody who's saying that their father is in a care home and they don't have the power of attorney, and the GP had been relying on care home staff who were describing the father's behaviour, and he was on anti-psychotic drugs for nearly 11 months, and these were only stopped after from an adult safeguarding team member. And now he hasn't been on medication for 8 weeks. It doesn't seem to be any problem for him now. The question is it a question of professional judgment, or can you really challenge the long-term prescribing of drugs by GPs?
So ideally, the ideal situation is that you're having the prescriber is having a conversation with the person and their carers and family. Now, it can be tricky if a family member is not available to have those conversations and perhaps is not also seeing the behaviors every day themselves. So I can imagine if you're living in a care home and as a family member, if you're visiting once a week, you might not be aware that actually that, depending on how much the care home staff is telling you, that they're getting very distressed in the morning, or they're not sleeping at night, or they're really low in mood. So quite often it is reasonable that the care home staff who are observing that person every day would be more au fait with what behaviors are happening all the time and what symptoms they're struggling with. But when you say the professional decision about using any medicine is about reducing distress and reducing risk. It's not about making, life easier for a care home manager. And yes, you can challenge the need for, absolutely, as a family member, you can really say, really, is this needed? An antipsychotic seems quite a powerful medicine to use, and you can certainly say what has been tried instead, because like I say, all the non-pharmacological options should have been tried. But if you're not there every day and the care home staff is saying, no, your parent, your relative is really distressed at this time, and actually he's putting himself at risk, it would be reasonable for a prescriber to take that point of view on board, so it is, I'm not saying that family members, one should trump another. It's absolutely about what's the best interest for the patient to stay safe, to not be distressed. And the short-term use of antipsychotics sometimes is very appropriate. And I'll also comment on that kind of 11-month, like I say, it's ideal if they could only be used for kind of 6 weeks, but sometimes it does happen that they are needed for longer because somebody has, in trying to remove them and trying to review them, the behaviors return. And with antidepressants, we would expect them to be used for longer. So it's really clear the antipsychotic and antidepressant treatment plans are different. I hope that answers the question.
Thank you, Ola. That person has just commented, just to add that that he was having apparently severe side effects, but they felt that the care home didn't report the side effects. Is that common? Have you come across that?
I think there's probably a lack of training in care homes. I mean, care home staff, they've had such an extraordinary time and over these last few years, and they've had to learn so much about so much. So is every care home staff au fait with the potential side effects of antipsychotics? I doubt it. And some of these side effects, they just seem extraordinary to be, you kind of think, how could that be related to the drug? Constipation, why would you think that the drug would cause constipation, or even these movement disorders? So I don't know quite what side effect this chap was having, but it's not obvious to an untrained person that this side effect, tremor, stiffness, is because there's another medicine added to the drug chart. One would like to think that care homes allocate key workers that might do the 2 and 2, something's changed here and actually this is struggling. But also it isn't helped by the fact that sometimes the side effects can take a while to develop, and especially if they're dose related. So you'll say somebody might have started risperidone low dose and be fine on it. And then the dose will go up slightly, and they'll develop a side effect, and the staff will think, but he's been on that drug for ages, it can't be the drug. But it's because it was the dose changed. So I can understand. I do think we need to do more to educate care home staff about side effects of neuroleptics and all medicines, perhaps, and give them the resources they need. I could see how that might happen, unfortunately. But that's why the doctor needs to be reviewing them regularly, because the doctor will spot it. They know what the side effect of the drug will be.
Thank you, Ulla. I'm going to bring in Mary for a question now.
Yeah, again, it's more of it's partly a response to the last question. I think you've been very clear that not all staff understand the side effects of the drugs.
Yeah.
But what I worry about is that if somebody is quiet, not as confused, maybe not shouting, more withdrawn than they were because of the drugs they're on, they're more likely to be left on them and not reviewed, particularly given the staffing situation that we have in care homes. But I think I don't condone it, but I can understand maybe staff don't understand the impact of these drugs. But what worries me more is the fact that they don't seem to understand the reasons for the distress, which might be the constipation, it might be pain, it might be hunger, it might be somebody who is frightened or scared. So that is unforgivable. But that's very easy to how I can't even find the word for it now. But to get rid of those symptoms by giving a drug and keeping it unnecessarily.
I think though that certainly. So in fact, the last 10 years we really have seen a change in approach, and 10 years seems like ages, but it's actually it's probably 15 years, but. It was 2009 there was a big report done that looked at prescribing of antipsychotics in people with dementia, and it really identified that overprescribing was a thing and was a significant thing. And there's been a huge amount of kind of trying to change attitudes, change practices, training and education that's gone into it. And lots of dementia care programs have been put forward. And I think most care home staff need to complete, level 1, 2, 3 dementia training programs. So I agree, it isn't appropriate for somebody who works in a dementia home not to be aware of the non-drug options for how you manage distress, and to be kind of thinking about that as an individual on an individual basis. I think, that's very much expected. And I'd like to think that practices really are evolving and that we are seeing better care, and, care homes taking really detailed histories for patients when they come into homes, so that they can understand that person really well, their cultural expectations and everything, and in case any kind of miscommunication leads to distress. But like you say, you've got to constantly promote this, because the drug does offer, to a certain extent, a quick fix. And it does, it can be very calming. And like I say, it's even amongst care home staff, there's a reticence sometimes to pull it out because it's doing a fantastic job in keeping someone quiet. But actually, whatever was distressing them however many weeks ago is possibly not an issue anymore. And so that, you know, they could be perfectly quiet and delightful without the drug. It's such a changeable feast, dementia. I think until you've worked with it, you can't quite believe that how much it changes, how much people change in such a short period of time.
Thank you so much, Ulla. We're very close to our end now, but just in the last minute or two, I wonder, just to wrap up, whether you could give any message or advice to our network of community organisations within the Irish in Britain network that might be wondering what can they do to support family carers and people in the community that might be in these situations. Is there any suggestion that you have for our community groups, our network of charities and community organisations?
My key message, I guess, in this is that medication review is a really positive thing. Medication review is not about saying you're wrong, the prescriber's wrong, this person's right. Medication review is about, it's a collective, collaborative conversation about medicines, how we can make the best out of them. So I would encourage people to think of it as a positive conversation, and as family members, as patients, you are a key part of that conversation. So you know, when we talk about medication review, we're not talking about stopping a medicine immediately. It might be after the review that you say, this is doing brilliantly, it's absolutely needed, let's stay with it, there's no side effects, etc. But don't be fearful about requesting it, and don't be fearful about being part of that conversation. It's a really important thing. So I don't know if that's the kind of thing you'd like me to say.
Thank you so much, Ulla, from all of us, and thank you, Dr. Mary Turkey too, for joining, and Ellen, our health coordinator, and thank you to everybody that's tuned in today. And if you would like to listen back to this recording, we will be making it available through our Irish in Britain website, where we have lots of resources on our Quivna programme around memory and dementia, lots of support for reminiscence activities, and also resources, very importantly, for family carers, people that might find themselves in a situation where they're looking after a friend or a relative or a community member who may be living with dementia. So thank you to everybody, and we're going to close the session now.
Thank you.